respected colleagues, I'm indebted to the organizers for this opportunity. My topic is peripartum cardiomyopathy. It took 80 years to be recognized since the first case was detected in 1849 and the disease was recognized in 1930 as a pregnancy-associated cardiomyopathy. The other nomenclatures being Meadows syndrome, Zaria syndrome, postpartum myocarditis, and peripartum cardiomyopathy. To define this pathology, 2010 ESC group stated first, development of heart failure towards the end of pregnancy or within 5 months following delivery. Second, absence of another identifiable cause. Third, LV systolic dysfunction with an ejection fraction less than 45%. The LV may or may not be dilated. Regarding epidemiology, it is extremely common in Zaria, Nigeria, due to local Hosha custom of eating kanwa, a dry leg salt, for 40 days after delivery. It may lead to hypervolemia, hypertension, and finally PPCM. It is also common in Haiti and rare in Japan. In India, the incidence is 1 in 4,025 according to the latest data on 23rd March 2018. Global incidence increased, maybe due to improved diagnosis, increased maternal age, preeclampsia, maternal CV risk factors, and multiple gestations. The etiology, it is multifactorial and largely unknown, being final common pathway being increased oxidative stress, cleavage of prolactin to angiostatic NT16 kilodalton fragment, and impaired VEGF signaling. Impaired VEGF signaling is a manifestation from upregulated soluble FLT1 transcriptase protein. The prolactin has a fragment which is 16 kilodalton fragment. It can cause endothelial damage and myocardial dysfunction. Inflammatory cytokines like TNF, interleukin 6, CRP may have a role. Role of myocarditis is uncertain. Abnormal immune response where escaped fetal cell lodge in cardiac tissues. Genetic predisposition, there is some polymorphisms are detected, and hemodynamic factors, exaggerated response of LV remodeling and hypertrophy is there. Risk factors are age more than 30 years, African descent, pregnancy with multiple fetus, history of preeclampsia, eclampsia, postpartum hypertension, cocaine abuse, more than 4 weeks oral tocolytics with beta agonists like carbutalin. Relationship with diabetes is confounded by other risk factors, and selenium deficiency has conflicting data. Regarding clinical manifestations, it is rare before 36 weeks, though some case reports are within 32 to 36 weeks, and the sign symptoms are largely of heart failure. The important thing is initial diagnosis may be delayed since non-specific fatigue, shortness of breath, pedal edema simulates normal pregnancy. LV thrombus was seen in echocardiography in 16 out of 100 patients with mean ejection fraction of 26% in a series. Diagnosis, the mainstay is echocardiography, where less than 45% ejection fraction was added in definition to prevent inclusion of disorders. Those mimic systolic heart failure like accelerated hypertension, pulmonary embolism, systemic infection, severe diastolic dysfunction, amniotic fluid embolism, or preeclampsia. BNP, chest X-ray, CMRI, endomyocardial biopsy, and catheterization have role in selected cases only. Viral bacterial culture or viral title like Coxsackie-B are not indicated. Variable presence of LG in CMRI reflects diverse process of this disease. Persistence of LG denotes poor recovery. No pathognomonic EMB finding is seen till now in PPCM. The management, again, it is a largely heart failure management. Oxygen supplementation and assisted ventilation as per need, optimization of the preload, hemodynamic support by inotropes and vasopressors, symptomatic relief with diuretics, and when possible, institute chronic therapies to improve long-term outcome. 15 to 20% with PPHF carry mutation known to induce cardiomyopathy for genetic consideration of management. Now, patient with genetic abnormality may have a predisposition to develop heart failure triggered by physiological stress or pregnancy and delivery. Another thing is arrhythmia management. Arrhythmia is seen in 18.7% patients in a large inpatient database study of 9,841 patients. 4.2% are having VT, 2.2% are having cardiac arrest. Some smaller series reveal 20 to 25% cardiac arrests, though. Atrial fibrillation usually seen in 3 to 12% cases. Specific indication for ICD are not established in PPCM. 20 to 70% PPCM usually recovers to normal by 3 to 12 months. So ICD is to be deferred. So also CRT, at least 3 to 6 months. Wearable defibrillator again is not without its risk or concern. Now, regarding anticoagulation issue, the data for using anticoagulation is inconclusive for reducing events of mortality. Exception is bromocriptine treated patients, where bromocriptine increases the risk of MI or stroke. LV systolic dysfunction with or without heart failure, without LV thrombus or other indications, anticoagulation is not recommended recently. Definite indication of anticoagulation in PPCM and sinus rhythm is intracardiac thrombus and evidence of systemic embolism. Regarding the advanced management, mechanical circulatory system should be considered as bridge to bridge or bridge to recovery therapy. Temporary device should always be preferred. Venoatrial ECMO may lead to increased prolactin. In these cases, bromocriptine in high dose 10 mg BD is helpful. Heart transplant in PPCM has worse outcome, increased mortality, increased rejection, poor graft survival, and increased rate of reimplantation occurred in different studies. Immunosuppression is not recommended. IVIG efficacy is not confirmed. Apheresis and treatment with miRNA 146A are upcoming. Now, the controversial role of bromocriptine. Bromocriptine reduces prolactin production by dopamine agonist action. It may improve outcome by eliminating the cleaved form of prolactin despite the activation of the cleaving enzyme. Bro heart failure concluded that it was independently associated with greater LV functional recovery at 6 months and at long-term follow-up. Dose is 2.5 BD 2 weeks followed by 2.5 OD 6 weeks. 2019 ESC position statement from Heart Failure Association gave a weak recommendation for bromocriptine use and suggested kevargoline as an alternative. Other factors we have to discuss is delivery. If the patient is hemodynamically stable, go for vaginal delivery with epidural anesthesia. If not stable, plan cesarean section with central neuraxial anesthesia. Early delivery is not required if maternal and fetal conditions are stable. Regarding breastfeeding, prevention of lactation is needed for severe heart failure only due to harmful effects of prolactin subfragments and high metabolic demand of lactation and breastfeeding. If clinically stable, then breastfeeding can be done as long as it is compatible with heart failure treatment. If breastfeeding is decided, then ACE inhibitor ARB should be avoided. Contraception. It must be reliable. Persistent LV dysfunction can lead to high risk of recurrence. Sterilization may be required for patients and or partner. Estrogen-containing contraceptives are avoided due to enhanced risk of thromboembolism. Prognosis, the most important thing in PPCM. First, complete recovery occurs in 50%, persistent symptom occurs in 25%, and the complications in the rest of 25%. Mortality is 3 to 9%. Recovery of LV function usually takes 6 months, but may take even 5 years also. Recovered patients may have subtle systolic or diastolic dysfunction with reduction of maximum exercise capacity. Extracardiac morbidity may occur in the form of brain injury, CVA, or cardiopulmonary arrest. Persistent ejection fraction more than 50% for more than 6 months, then you can allow stepwise weaning of heart failure therapy, and echocardiography should be done 6 monthly. So, adverse prognostic factors are increased NOIHA class, less than 25% ejection fraction, black race, indigent status, multiparity, 30 to 35 years of age. Predictors of persistent LV dysfunction, less than 30% ejection fraction, less than 20% fractional shortening, IDD more than 6 cm, reduced RV function, raised troponin T, black race, and diagnosed during the pregnancy. So conclude, PPCM is a multifactorial disease of unknown etiology. We have to think about the signs symptoms of heart failure, and it can simulate the normal pregnancy also. The management is largely of heart failure with special reference to anticoagulation and arrhythmia therapy, and the concern of delivery, breastfeeding, and contraception are to be kept in mind. Thank you. Thank you for patient hearing.